morning. I'm very pleased to be here today to talk about disease prevention, advancements and challenges in outreach and surveillance. It's a complicated title, so I think it might be helpful to unpack it a little bit. First, with regard to prevention, just by way of review for all of you in the room, primary prevention is the prevention with regard to asbestos-related disease, is prevention of asbestos exposure in the first place. If you can do that, you can eliminate the risk for developing disease. Secondary prevention is the prevention of worsening of disease once it has developed. For lung cancer, for example, this may take the form of early detection. For asbestosis, this may take the form of vaccination against influenza, against pneumococcal pneumonia, and other infectious diseases that might adversely impact the lungs, just adding insult to injury. And health education, of course, is critically important for all asbestos-related diseases, such things as stopping cigarette smoking, for example. Outreach is directed primarily at primary prevention, whereas surveillance is directed at secondary prevention. Surveillance is monitoring of an individual or populations of individuals who have experienced a certain exposure and are at risk for certain diseases. It is not the same thing as screening. Surveillance determines occurrence of disease and also prevalence of disease. So surveillance provides the basis for the argument that we need primary prevention. And of course, outreach targets not only primary prevention, but also secondary prevention, encouraging people to take steps that will prevent worsening of their disease. The poster child for outreach in the service of asbestos disease prevention is the ADAO, this organization here, as all of us in this room know. ADAO, as you've heard already this morning, and we've only just started, is constantly expanding its scope of influence with education and advocacy on both a national and international front. Recently, as Linda mentioned, the ADAO targeted TSCA's so-called reform with the Chemical Safety Improvement Act, the so-called Chemical Safety Improvement Act, and fought for its, to keep it from passing. This is an act that made it very hard to ban harmful chemicals, provided grossly inadequate protection for those potentially exposed, lacked firm action deadlines, required unreasonable burden of proof to show that a chemical needed to be further and more stringently regulated, and inhibited state action in favor of federal action. A proponent of outreach in his own right is this gentleman. This is Dr. Bernardi No Ramazeni. He's the so-called father of occupational medicine. He practiced outreach in his medical practice in Padua, Italy in the late 1600s and early 1700s. He also did outreach through the publication of a treatise entitled De Morbis Artificum. This was published in 1713, and during the 300 or so years since its publication, it has continued to reach out, certainly to physicians who read this. I quote from this text repeatedly when I give lectures on occupational lung disease. So he was a very important advocate of outreach and education. The Collegium Ramazeni was named for Dr. Bernardi No Ramazeni. The Collegium is no slouch when it comes to outreach in the service of asbestos disease prevention. It's an organization of 180 scientists and other occupational health professionals that has been very active over the last couple of decades. In June of 2015, the Collegium published its 18, count them, position statement calling for a ban on all mining, manufacture, and use of asbestos, including chrysotile asbestos. This position statement updated the Collegium's focus on global health dimensions of asbestos and asbestos-related disease. It pointed to the global burden of asbestos-related disease, which we've heard about earlier this morning, 107,000 deaths per year from asbestos-related disease, and also highlighted what we know, and that is that the burden of asbestos-related disease falls disproportionately on those who live in countries that have failed to ban asbestos. Hello, the United States. There are challenges to outreach in the service of asbestos disease prevention. These include a lack of knowledge on the part of physicians, hard as it may be to believe it's true, lack of knowledge on the part of the general public, government denial and obstinance with which many of you in the room are well aware, to wit the recent battle over the CSIA, corporate self-interest and financial reach, and this has been particularly evident in the chrysotile debate. And as Dr. Frank pointed out this morning, it's an absurd debate. The debate is that chrysotile asbestos does not cause cancer. It is not a carcinogen. It does not cause malignant mesothelioma. Scientific self-interest and conflict of interest, which obfuscates the data about relationships between asbestos exposure and disease, particularly chrysotile asbestos and malignant mesothelioma. Complacency on the part of the general public. There are many who think that asbestos exposure was a thing of the past, and therefore so is asbestos-related disease. And then finally, bias in the judicial system, which tends, at least in some cases, to favor corporate interests over the interest of the asbestos victim. There is good news on the front of surveillance in the service of asbestos disease prevention. In 2010, this article was published in that venerable scientific journal, the Wall Street Journal, noting the fact that a randomized controlled trial that was being conducted by the NIH was stopped because its primary endpoint had been reached. It was stopped prematurely. The primary endpoint was a 20% reduction in lung cancer mortality. The reason, screening with low-dose chest CT scan. In 2006, 4 years before the NIH study was terminated, the International Early Lung Cancer Action Project published an article that showed an estimated 92% 10-year survival for lung cancer in those individuals whose lung cancer was stage 1 at the time of detection and who had their lung cancer resected within 1 month of diagnosis. That's an astonishing survival rate. In addition to the 20% reduction in lung cancer mortality, a 6.7% reduction in overall mortality was also observed somewhat unexpectedly. For malignant mesothelioma, the advances are not quite as striking. They are nevertheless there. There's ongoing research looking for biomarkers, for example, that might be used as a screening tool for malignant mesothelioma in the same way that low-dose chest CT scans are used to screen for lung cancer. There's ongoing research to identify genetic markers that might indicate predisposition to the adverse effects of asbestos exposure, particularly malignant mesothelioma. Now, there are challenges in the area of surveillance for asbestos disease prevention. One is that the benefits of low-dose chest CT scan screening to reduce risk for lung cancer are modulated by the fact that insurers will only pay for low-dose chest CT scan screening if the risk is related to cigarette smoking. If your risk is related to occupational exposure to asbestos or another lung carcinogen, insurers will not pay, nor are insurers like Medicare required to pay. This really has to change. For malignant mesothelioma, unfortunately, I have mentioned this in years past, there is still no effective screening tool for malignant mesothelioma, which will do for that disease what low-dose chest CT scan screening appears to have done for lung cancer. There are challenges on the regulatory front, as Linda mentioned earlier today. One is the fact that the asbestos standard was promulgated by OSHA, the OSHA asbestos standard, in 1994. Its medical surveillance provisions are outdated. We know a lot more now than we did then. The rulemaking process is arduous, as we all know. So even though there are, we lack firm data in certain respects to say it's time to change the medical surveillance provisions of the OSHA Act, there is sufficient basis to begin to look at the Act, to begin to look at medical surveillance provisions and say, look, we need to start reviewing these provisions and we need to start thinking about changing them. For example, in my opinion, they should contain some requirement for low-dose chest CT scan screening for people at risk for lung cancer as a result of occupational exposure to asbestos. But if past is prologue to the future, and if the ADAO continues to work as it has, and I have no doubt that it will, then I think there's reason for optimism. Thank you.